Okay, so your three, or this is kind of split into two parts. The male GU is kind of split between the prostate and the kidneys. I think both of those are pretty important. Your focus on your prostate is kind of telling apart, being able to tell apart um, kind of prostatitis versus BPH, and then kind of like issues with prostate versus cancer, and a big focus on your TERP, understanding how that kind of goes around post-op, pre-op for that. While your kidneys, your big focus is going to be telling apart nephritic versus nephrotic.
Compare and contrast.
Yeah, so here I have like a picture for you guys that we'll go over. I like this one a lot because yeah, it has like the Burger King guy, and it actually makes sense based on it kind of a picture kind of explains it, but I think the pictures help me a lot with remembering it, so that should be good. I took a picture of the slide here. I think this one's pretty important to keep mind of. Kind of has a good summary on nephritic versus nephrotic. And then testicular cancer, I don't particularly think we'll have time to cover it entirely, so I actually wrote that one out fully for you guys with and then alongside like this picture. So everything I have on it in maximum detail. So this one I didn't think we'd have time to cover. So just here. Um, yeah. So first, let's kind of go through just the prostate. This is a picture of a prostate that's enlarged due to BPH, because that's what we're going to go over first. So I wrote out some things just to make it go a little bit faster. So the definition of your BPH, kind of in the name, plasia, meaning growth, development, hyper, meaning more, like high, meaning there's an enlargement, but it's benign because it's not necessarily like a tumor or cancers. It's going to be an enlargement of that prostate tissue. Um, and I believe specifically they say it's like an increase in the reproduction rate as opposed to just pure hypertrophy, like an increase in cell size. It's non-cancerous. But you can see here how the increase in that prostatic tissue is going to be causing um, some constriction and pressure. You can call it even stenosis of the urethra and like your where you pee from. So people with BPH are going to have a harder time peeing, and people with BPH you'll see take medications to slow that down, but they might even be chronically on a Foley catheter, which is why people with BPH, you can imagine they're going to have issues with UTI and stuff like that. You'll have the UTI from both the Foley being in place for so long. You might even have, if it gets really bad, some of that urine might even start backing up into the ureters, might even back up even further and back into the kidneys, which is kind of hydronephrosis, stuff like that. And some of that urinary stasis, if you guys remember, I think maybe in like 210 or 212, urinary stasis, when all that urine is just kind of allowed to stay in the bladder, it becomes a breeding ground for bacteria. So another thing that could increase the risk of a UTI, and even worse because your UTI um, is something that can lead into like a kidney infection because they're all kind of connected through that ureter, and maybe even can lead to sepsis. So just things to keep in mind, general information there. So some risk factors that I included for you guys includes family history and some other risk factors. And a lot of these risk factors are similar things that you would think about with perfusion, atherosclerosis, diabetes, hypertension, your PVD, your CAD, obesity in general. So um, I think like an easy, like a way you can kind of remember that is that a lot of this stuff causes narrowing of vessels. And even though this is not like a blood vessel or anything, it's a urethra, it's still kind of causing constriction of a vessel. So maybe you can just try to cluster it down that way, just if it helps you remember. Even though they're not like you think of this as like hard stuff, and this isn't necessarily like a vessel. It's just like a way for it to cluster in your head because you guys are going to have a lot of topics that are being covered. So the best, whatever you can find to simplify things and cluster things is going to be the best that you can do because there's so many topics being put into play for your 220 final, and there's only so much brain space. Okay, any questions on what I kind of talked about? Just like a quick overview before we kind of start getting into the more interactive part of the interactive part of BPH, like or the outlines. Mhm. Okay. So what are some signs and symptoms you guys can think about for your BPH? So this is someone that is having this narrowing of the urethra. Um, what can you guys think about? And we talked a little bit about some of the things that I said are possible.
Dribbling.
Dribbling is a very, very common thing, essentially caused by the pressure being placed on it. Dysuria, so you can have painful peeing, um, difficulty urinating. So dysuria can mean difficulty peeing or pain and difficulty urinating. Uh, yeah, so you can have urinary frequency. So you can have either higher or lower. I think depends on where the constriction's at and exactly what's going on. But a lot of the time, people with BPH are going to have urinary retention. So like I would say it's kind of like a change in urinary frequency. Yeah, it depends on the condition. Let's see what you guys said. Nocturia, yeah. So again, change in urinary frequency, so that can come with nocturia. It can come with urinary retention. And something that you'll notice is that for your guys' manifestations, you'll see that it gets um, constantly kind of overlaps a lot with your prostatic prostatitis, which is just an inflammation of the prostate. Which, if we're having overgrowth, it's almost it's gonna lead to the same thing as an enlarged prostate from same symptoms. Different, yeah. Like Caitlin said, if you could hear, it's gonna have similar symptoms. It's basically gonna be two things leading to the same thing, like calculus, how two different people, different side of the world, both came up with calculus at the same time. Um, you didn't know that? Yeah, kind of like that. Both your BPH and your prostatitis, your inflammation of your prostate, different mechanisms, but they both end up leading to pressure into that your urethra. So what else did you guys mention? You guys mentioned nocturia, urinary retention, urinary urgency. Do you get a fever for BPH? No. So that's one of the things that you want to think about. Is this related to your prostatitis or your BPH? So we will kind of try our best to split them apart. So maybe we can start because this is so similar. I'll start typing in the prostatitis, and we can just kind of direct contrast. So here, the prostatitis, I said this is an inflammation of the prostate. It can happen with those with BPH because, like I mentioned, there can be bacterial growth happening, UTIs, inflammation of the prostate, all that stuff. So this can also just happen due to you're like a transient, generalized inflammatory episode, but it can also be caused by bacterial. But some things that set apart your prostatitis is you'll have fever because it's bacterial. You can have um, discharge from the penis, or well, it would be no, yeah, the penis because women don't have prostates. So you have a discharge. You can have cloudy, malodorous urine. So that's like a big sign that you have some sort of infection. Would be the cloudy, malodorous. Is the pain for both severe or moderate? I would say the pain. I think pain is more associated with infection than anything, but I would.
Between prostatitis and BPH.
Yeah, I think it can include them both, but between one or the
Definitely
other.
be included in both. It depends on the degree of the inflammation and prostatitis, how much is being constricted, and BPH thing, how much is being constricted and what symptoms I would have. So like if you could have dysuria, but if they're like, let's say it's to the point where they are retaining a whole bunch, they're gonna have a lot more pain than someone who's just like, oh, we're just dribbling every so often. Depends on the severity, as they progress through the course of these conditions.
pretty much. Yeah, but this can also have some of the same symptoms. Have all this stuff. The main thing I think that really separates your infection or your prostatitis versus your BP, purely BPH would probably be um, these three right here. Which makes sense because if you're having an infection, you can imagine you'll have a fever. If you're having an infection, you can imagine there's going to be like a nasty, gunky discharge. Your urine will get cloudy. It starts smelling bad. It's like a wound. You'll have that nasty discharge. You'll have that nasty smell, and you'll get a fever if it's like a wound infection. Yeah, that's kind of how that goes. You'll still have very similar symptoms. So have the if urination, it changes in sorry, changes in frequency. So when you have patients with these symptoms, that maybe it's early process of prostatitis, maybe you don't have this stuff happening quite yet. You want to think about whether this is BPH related or it might be an infection. You might be seeing changes in the white blood cells. You might see that changes to the like a shift to the left happening. So if you guys remember, that's when you have an increase of your bands, your immature neutrophils. So that's like a sign that there's an infection starting to go. Even if your white blood cell count, maybe your white blood cell count yesterday was like 6,000, today it's like 8,000. Technically within normal limits, but you see the trend. You'll see the shift to the left, so you'll see your bands increase and stuff like that. So just general infection things to think about. Any questions on that? Okay. So what about some diagnostics? And we can kind of include both diagnostics. Some things that you might have done. We can kind of you can think of whatever for both. Because we'll talk about both. Yeah. So CBC. I like it. So what are you doing with those? What are you checking for those? So with the CBC, what are you doing? What are you specifically kind of we talked about it, but yeah. So your white blood cell count. So with BPH, you're not gonna have an elevated white blood cell count, typically. But it's more just to kind of rule out infection, like the prostatitis. So kind of like how someone with let's say someone came in with like shortness of breath and chest pain, you can infer that they might be like it might just be a heart attack. But you still do like a chest X-ray to see if there's any pulmonary stuff going on. You do these to rule things out. So same idea here with yeah, you want to always cover your bases. So the urinalysis here you would do to check for presence of bacteria. So again, rule out infection, check for presence of bacteria. Let's see. Let's mention ERC. UN and creatinine, so that would be in a BMP. So your BMP would have digital rectal exam. That's something you can do as well. Let's see. Yeah, BUN and creatinine. If you're gonna have issues with um all this stuff, you can check to see if there's urinary retention. Um, Urinary retention because you can have it can lead to hydronephrosis, like we talked about, which is the backup of urine or some sort of fluid in kidneys. And when that starts to happen, um, it might lead to infection in the kidneys. That's where some of your pyelonephritis can start happening and stuff. Post-residual void, that's a really good one as well. So your post-residual, yeah. So let's see. Do you guys remember what your normal is for that? Sure. So that's good for that. So you have the values on that. So I'll hit you out with that. So I think I've seen the hospital depends. I think at my place it's like less than 1.2 or less than 1.1 is normal. It depends on your place usually. I think on average, because I know Sebastian Rowe, I'll go for within normal limits on. Normal limits is your creatinine less than, I'll do go kind of like an average of that. I'll do 1.2. And then your BUN above 20. I've seen from 20 to 22 less than. I think my facility does 22 for your upper limit, but depends on where you're at. Looks like most of you agree with 20, so we'll just keep it 20 because I think that is what we learned here. So now let's talk about that post-residual void. This is from 210. Do you guys remember what is considered abnormal?
Yeah.
And then how do you find the post-residual void? Sebastian says 300. Sebastian, you go to Lakewood, right? Yeah. Is that correct? Yeah. So that's actually exactly the policy for Lakewood. I believe in 210, you guys were taught 250, more than 250. So we'll stick with that number. But yes, Lakewood policy is more than 300. You can call the doctor and have an order for a Foley catheter being placed. And how do you find that one? How do you find the post residual void? What's what you can do to get that? Exactly. Is that something you need a doctor permission for? Or can you do it on your own? Yeah, that's something you can do on your own. So if someone's been having issues with peeing, not getting any output, you can try to see what's going on with the patient. Do they have distended bladder? So you can push down on their bladder, see if they feel like, oh, it's pushing down. Can you feel it distended and stuff? You can go do a bladder scan and kind of see how much is being held, retained in there. And it depends on policy, but here you were taught more than 250, consider calling the doctor for a Foley catheter. Yeah, so it looks like in your facility they also do 300, yeah. For me as well, at Lakewood, we did a bladder scan and the patient I think was at 270 or something, which according to 210 would be enough, but their policy there was 300, so we didn't do anything in regards to that. And then obviously, ask the patient if they need to pee because they might be retaining, but it's not because they can't pee, it's just because they didn't feel like going to pee. So make sure your patient is capable of peeing first. Don't just make the assumption. In that case, you would be like, hey, do you need to pee? Can you pee? So you probably would do all that before you even get the bladder scanner out. But yeah, just some things to keep in mind. Let me see what else. I think you guys mentioned your yeah, you can do a PSA, so that is your prostate specific antigen. Let me see if you guys have a specific value here.
I think there's specific values, I just don't remember if that was taught.
Yeah, the KUB, that's the ultrasound of the kidneys, ureter, bladder. The antigen. I don't know if there's a specific value of it.
I'll look for it.
Yeah, Ken's gonna look for it. We said digital rectal exam. I guess it would be. That's your assessing for prostate cancer. So what should it be like? What's a normal prostate? Non-cancerous prostate feel like? Yeah, exactly. That's a spongy. Meanwhile, like a cancerous one potentially would feel firm and hard. Although I believe the normal can be firm and spongy, but the cancerous one will feel firm, it will feel hard. Okay. Which one do they do first? Would they do a PSA first or a digital rectal exam first? Yeah, so they go PSA, and if you have high numbers, then you go for a digital rectal exam. Okay, so a value over, you're saying a value, okay. Value over 4, consider doing a DRE. Yeah, and then you can do the truss and then all that good stuff. Oof. Yeah, you always do least invasive first. So what's gonna scar your patient less, getting the PSA or getting the finger? Belief. I believe there's like I think like a value system where they might keep you in a monitoring state where they keep assessing you over a certain period of time. But I think over four, that's when they're kind of looking for cancer. I think we go over that a bit later when we go into prostate cancer. For now, let's just kind of focus in on this. So there's a lot of labs here, um, but it kind of goes with pretty much everything you're doing. So what about some patient education that you guys might be thinking about telling your patient?
Figure out how to. See.
Drink less caffeine. What else do you guys say? So Caitlin also responded to Jennifer. Chance of having prostate cancer goes up as the PSA level goes up. There's no set number that can tell for sure.
So it's saying four is like oh, hey, what's going on here? But they found that people,
Uh-huh.
that ended up with prostate cancer
No,
and
you got
whatnot
50.
had levels below four. So there's no definitive set scale. But they do know that over four is more associated.
Okay, that
It's
makes
bigger,
sense.
so to say. That was straight from PowerPoint.
Yeah, so we mentioned avoid caffeine. We can also avoid caffeine and alcohol as well. Yeah, that's a good one. So we want to educate them on their water intake, as we mentioned. Don't drink large amounts of water before bed. You're gonna, or one at a time. Um, kind of spread it out. Water intake. Um, a sitz bath that could be interesting for what, like itching and stuff is typically what that's for. I'll do a few. Yeah, Kegel exercises are good to increase the strength of your bladder
That is for
for the prostatitis.
prostate. Ooh, actually.
Another thing that they can do is like catheter, so education on catheterization. Teach them about Crotty and stuff. They need to there's a specific catheter. I remember going over um you guys with you guys, showed you guys like a picture of the catheter. What kind of catheter would they use? There's a specific type of catheter. Do you guys remember the one that's kind of curved? Trying to pull from your 210 knowledge from.
Jeez, wait. I'm trying to think of the name of that. It's not a straight cat. Well, what was it called?
Oh. So yeah, they could do stray cats, but there's a specific type of cat. So a specific kind of tip, tip, different tip.
I almost called it a French, and I don't think that's right.
It's kind of a French word.
Oh, I got it.
You got it? All
I
right.
got it right. I tried so long to figure out how to say it.
Remember that. This is a thing. Some people are just on a chronic catheter and they have increased risk of so you would also be education on infection risk. Do you guys remember what it's called? Starts with a C. Kind of like a French sounding word. Starts with a C. So straight cath and an intermittent are the same thing. Not a condom catheter. Condom catheter, we can Caude. Yeah, that's correct. I think it's spelled like this.
You spell it.
Yeah, Caude with like a E with the accent. Caude catheter.
Oh, I
So
don't look at that one.
yeah, so let's take a look at what that looks like. So yeah, this is back from all the way, all the way back from 210. Yeah, with the apparently it's French for elbow.
Does it look like an elbow?
Oh, maybe.
It's wait, slightly curved.
Yeah, it's got a slight curve here. So here, this is actually the exact picture I actually gave you guys during that time. You can see the straight tip versus the curved. Take my picture out. You guys kind of saw that. So, an image, a new tab. See what we got. Boom. You can kind of see how that curve. This one's preferred. Yeah, a Coude tip is preferred. It's going to make it easier to get through squeezing of the prostate here.
Now, I think the thing is if you can correct me on this,
Yeah.
or tell me if I'm right.
Talk a little bit louder. I'm not sure how loud you are.
Hello. I believe only advanced practice nurses or MDs can insert a coude, whatever you say it.
Coude.
I feel like I remember that being mentioned in my 212, but I was not entirely sure if you were told the same thing.
I don't recall, but let's look it up.
Okay. You have to kind of like maneuver it different.
Says nurses can, but it requires specialized training to do so. So
like a certification or something.
Yeah.
Okay. You have to have training on it to do it.
yeah, you'll need training to yeah, learn how to actually insert it. But the purpose of it is to make it easier to kind of go through here and make it actually into the bladder. All right, awesome. There's a lot of really good memory going on. Lots of really good stuff happening here.
My memory is terrible.
Yes. Yeah, so there's some things like call the doctor, call the MD, or painful urination. Might need just something, or cannot if they cannot pee or their peeing hurts. That's something worth calling the doctor for. What about some management? So we can go whatever pharmacological versus non-pharmacological, whatever you guys want on that. Yeah, so your alpha blockers. So perfect. So your alpha blockers, from pharmacology, you guys know your alpha beta receptors are your sympathetic nervous system. That's your fight or flight. If you're blocking them, you're kind of tipping the other way. So that's the rest, digest, and sex, and and that also includes the ability to relax. I believe your sphincters and all that urinary bladder stuff relaxes it, makes it more easy for you to pee for them. So some of the medications that you'll see, I see this one, I've seen this one the most, is the Flomax, the tamsulosin. And I think that's just the one. That's the one I see all the time for these. I've also seen another med. Let's see if you guys recognize this one. This one is finasteride. Has anyone given it or seen it? It's Proscar.
Oh,
Yeah.
wow, I just gave that on my last week.
Oh, did you?
I did. I looked at
Oh,
it.
yeah, because you told me you have to wear your things.
That was for tamsulosin, I believe.
Oh, shouldn't be. It should be the other way around.
It's for one of them.
Yeah, because finasteride is um eats your testosterone um kind of impedes you from it's a testosterone blocker basically. So if you don't wear your double gloves, it's going to affect your hormones. Yeah, so this is you're gonna double glove for this one. Handling, correct. Analgesics. Can you guys think of some non-pharmacological ones? Some non-pharmacological options? Tomatoes, yeah.
Oh wait, let me see if I can make one of these.
Tomato emoji. Yeah, so yeah, so non-pharmacological can include tomatoes, saw palmetto, yeah. And all of these have to do kind of with I think tomatoes its own like has a specific pathway with some of the things, but your finasteride and your saw palmetto are gonna inhibit testosterone. Specific, it's like very specific pathway. I don't think you need to know it that far, but it's just something you might.
Tomatoes are good for you.
What happened, Jennifer? Bad rest on the PowerPoint? You don't have to. I mean, you're probably gonna be on a catheter, or you're gonna be. You don't have to. You can get up for sure. There's nothing. I would say there's nothing specifically that makes you bed rest. Maybe after a terp, which we'll talk about later, but otherwise, yeah. Otherwise, you can exist still be chilling. All right, that seems like it's pretty good and complete. Your prostatitis, it's gonna be pretty much the same diagnostics. Diagnostics is pH. For your treatment, it's gonna be pretty much remember this is an infection potentially. So the one thing you might add on to that is like antibiotics and whatnot. Let me just see. Any questions on anything? Will you do a broad spectrum? I mean, typically the way things go is if you start seeing patient has some sort of infection, you would do all your cultures. You do cultures, your analysis, your culture and sensitivity, and then you would start broad spectrum once you kind of find out what's going on. And see if there's anything specific you can target, then you would switch over to narrow. That's kind of the general. Oops, doing that happen. That's kind of like your general guideline for how your antibiotics are given and stuff. Let's see if there's anything else here. I keep doing that. Ugh. Make sure I didn't miss any. Yeah, so the treatment's gonna include your antibiotics, yeah, antipyretics, pyretics, because obviously we're infected, so that would be your Tylenol. And what are we looking out for with Tylenol? Yeah, your sitz bath is another one that they can do that's different. That's gonna help decrease comfort and decrease inflammation. Yeah, and it's kind of in the name. It's like kind of like a. It's quite literally you're sitting in the bath. It's almost like no, yeah, you're quite literally sitting in a bath. Although that's not why it's called a sitz bath, but you are sitting in the bath. Anything else you guys can think about? Group hydration, yeah, equals pretty much the same stuff. Through hydration, you can flush out bacteria and stuff. They tell you for preventing UTI, not what kind of you want to be drinking water to prevent urinary stasis because if you're peeing more, that means you're flushing out stuff more. NSAIDs, yeah, they can be good for pain and stuff. But again, and you can answer me on this. What are you looking out for NSAIDs, and what are you looking out for Tylenol?
Liver function,
Say that again?
for your liver function.
Yeah, so your Tylenol, you're looking for liver function. It has an effect on your liver function.
And the NSAIDs is kidney function.
And this is kidney, yeah, exactly. So what does that mean? It means BU and creatinine. Urine output, which is something you're going to be checking anyways because the person's got issues with all of that going on. This one's your ALT. That's going to be your main one for liver, and you'll learn about that more in 232. You have your ALP, which is kind of like a blockage thing. It's showing you there's obstruction. Again, you'll learn more about that later. And your AST, which is kind of a somewhat general bilirubin and stuff. But yeah, you pretty much don't want to forget that. You always want to think about your Tylenol and your NSAIDs and how they affect kidneys and liver respectively. Or yeah, the other way around. You want this pen?
Um,
If not, there's pens on my bag.
oh,
See, Kellet says, do they ever give steroids for inflammation? I, I could see that.
Not for their prostatitis, BPH or anything.
Yeah. If you could hear Kaylin, she says, yeah, steroids can be in general can be given for inflammation. I'm not sure if you guys specifically went over it, but it makes sense. And so it's tool top. Tool softeners are specifically mentioned in your guys' points. I want to make sure that now prevent bearing down and straining. All right. And I do see Jennifer where on your guys' PowerPoint it did specifically mention bed rest for prostatitis. Probably just to decrease straining, if I had to guess. Maybe we can try this. And then you would still try your tamsulosin stuff. Actually, it looks like you double glove on both. Double glove on. Yeah, you double glove on both of those. I think it's because it can affect you. I think I think that's actually probably like the same reason you want to double glove with your nitroglycerin because it can absorb into your skin and cause some of the effects. Yeah, that's something to keep in mind. Any questions so far between prostatitis and BPH? They're pretty similar, but remember here we have those key differences in prostatitis with these three. So they both lead to basically the same stuff, but because the other one's an infection, it comes with a little extra stuff and it comes with antibiotic usage. All right, we're good to go. Now we can start talking about your prostate cancer. So we'll just quickly go over the risk factors. Sure, yeah. That can be a family history. Age can definitely matter. Remember, one of your highest risk factors for cancer in general is your age. Give me a sec. Yeah, so in general, your age. What else you guys got? Pretty much like a poor diet. So they specify kind of low in fruits, vegetables. Smoking. I think I remember looking this one up because I think it specified kind of like carcinogenic exposure, and it specified that there's not that much of a strong link with smoking and prostate cancer, but I didn't really think there were too many questions probably on risk factors. I think it's just worth noting stuff. Heavy metal exposure. Yeah, I saw chemical exposure with like Agent Orange. So for the people that got hit with Agent Orange in Vietnam and stuff. But again, just kind of get the general idea. No need to have a PhD on that. So let's talk about some manifestations. We did talk a lot about your PSA, your we'll do that, your PSA. Um, and here I think we went over like above 4. Want to try doing something first. Um, let's see. Yeah, let's see what else you guys mentioned. I think cancerous will be firm and hard prostate. So someone said painless. I believe that's right. Painless, urinary retention. Yeah, so you'll have bladder obstruction. So it can lead to urinary retention, dysuria, bladder infections, can lead to blood, blood in the urine. What's that called? Do you guys know what the name of that? Yeah, the hematuria. You can have NOCU, but it's typically asymptomatic in your ages. And because of that, that's why they recommend at a certain age just have it done for men, be asymptomatic at the start, but it's also more common as we get older. Mm. All right. So then let's talk about the diagnostics. We kind of already mentioned you want to go PSA first. You want to do this one first. Do first. It's least invasive, and it's also going to if you do this, it's least invasive, and if you were to do a digital rectal exam, it might actually stimulate prostate and cause it to release more. It can falsely elevate your PSA. So it's least invasive, also DRE. Elevate. That's the reason why. And then your digital rectal exam. E, we mentioned that I think men typically we are when we get to above 40, we want to start getting those done. And we mentioned the DRE, you're gonna see normal will have firm and hard. So yeah, transrectal ultrasound, and with that transrectal ultrasound, so that's the truss, the transrectal ultrasound, and needle biopsy. So they use that to kind of take a look and then get a biopsy. Because remember, your biopsies are always going to be your most accurate diagnosis. Done when PSA and DRR are your truss, your transrectal ultrasound. Okay. And I think there's a few others, but they're not as important. And then let's talk about management. Looks like Taylor already kind of mentioned there's like a watchful waiting period. So for those that have elevated PSA but no family history and stuff, they might do digital rectal exams, check your PSA every 3 to 6 months, kind of monitor your weight. So I guess something here I could write is that for late signs, the late signs include confusion and confusion due to metastasis. Yeah, I think like weight loss and bone pain. Yeah, weight loss and bone pain. Again, all of these weight loss is more like late sign, but then your bone pain, anemia. I'm sure. Yeah, it's just like in general cancer is gonna happen. Keep in mind like metastasis is you're gonna have the later signs and stuff. Where are we at? Watchful waiting if PSA is elevated. Got your smoothie? Okay, nice. Let's go.
Oh, yeah.
We're on management of prostate cancer. So we're going about elevated small nodule but no family. They might check PSA and your 3 to 6 months. Okay. What else can we do for management? So let's say they do have cancer, and some of the stuff you can do for cancer include radiation and chemo. So your chemotherapy involves some specific stuff, but I don't think it's too emphasized. Just kind of understanding it's radiation chemo is possible. The focus is a bit more on some of your critical stuff. So talking about right now, I think the surgical is called the prostatectomy.
Prostatectomy.
Prostatectomy. Yeah. Prostatectomy. Yeah. In which case you will do a removal of all of
I like this.
yeah, there's a few different types, but I think the focus is going to be more on your TERP. Your complications involve incontinence, erectile dysfunction, and I think there's a few things we could do like post. I think the post-op is pretty standard. Pre-op and post-op is pretty standard. Go over it just real quick, like standard pre-op. By this by now, we should know our standard pre-op and our standard post-op. Standard, but a special thing to watch out for is they can give antispasmodics. Ditropan, I think this one is also called erythrocholine or something. It's used for hyperactive bladder. Just remembering. Oxybutylene. Yeah, oxybutylene there for a hyperactive bladder. So we're gonna you and helps with the robot assist. No, not really. Not that I'm frankly aware. Fully catheter care. You can expect a light pink output. Or expect it to decrease. Expect the output to become light pink within 24 hours. And the rest is just standard care. Okay, any questions on that? And then we can focus on PERP. And then I think fast PERP, we start going into the kidneys. Over-the-counter drugs. Sure, it's just kind of like your standard, all your standard precautions. The only special thing here maybe is the octibutane, but I also don't think they emphasize this as hard. This drug you'll go over more in 232 with your spinal cord injuries. This one's good for decreasing the hyperactive bladder. How are we on time?
It's about 1:30.
Okay. Hopefully we can get it. So let's talk about your TERP. So your TERP is there for BPH. So once they've been like, okay, you have BPH, it's not prostate cancer. We're trying to manage it with what we can, but none of that is really working too well. It's not helping us out. We can go and do the TERP operation in order to essentially, as you can see here, this is your overgrowth of your prostate going on. They will straight up resect all that, create this open channel so that you now have that ability to eat. Okay, so this is done with medication, lifestyle changes fail. This is your gold standard treatment. Standard or pH that is not responding well to medications and lifestyle change. And here's that picture. Can the TERP be the removal of some parts and not the full prostate?
That's a good one.
That's a good question. Let me find out. Yeah, it says here they're able to do just part of it rather than the whole thing if they're able to. Yeah, it says the TERP typically is not removal of the entire prostate, just the parts that are obstructing. So they might not do the whole thing here. So yeah, I think this part here is technically the prostate. They're just getting rid of some of the overgrowth. So this little like plum looking thing is still your prostate. Or it's okay. So for the pre-op, this is again your standard pre-op, but we're gonna go through it just because you're gonna make sure they're MPO, you're gonna make sure they have informed consent. Do you see any anticoagulants? Because you don't want to bleed out, you're going to check your labs prior and call doctor, call MD abnormalities. So if patient has low electrolytes or something, they have hemoglobin less than 7, or they have an infection, you're not going to take them to get a surgery. Your standard stuff. You can before pre-op, it's good to give education for your post-op. So like post-op education, educate them on what they can expect for their post-op. You'll educate them on the continuous bladder irrigation, you know, what they expect to see, so they don't get freaked out by what they end up seeing. So now for you guys, I want to ask about what's the post-op. What are you guys thinking about? I'll add some of the obvious ones. So obviously, assess for infection. That is always going to be an important thing. Yeah, you're going to want IV fluids, your fluids. You're going to do vital signs. That's all. DVT prophylaxis, another obvious thing that you're always going to be doing. Assessing labs is never bad. Early ambulations, whenever possible. Avoid bladder irritants. So basically diuretics, caffeine. Yeah, assess for bleeding. Well, so far this has been all pretty standard. Post-op stuff, such as bleeding, can be your H&H. But it doesn't have to just be your H&H. Remember, you're treating the patient, not the labs. So if your labs this morning were a hemoglobin of 8, it doesn't mean they're gonna be at a hemoglobin of 8 the whole time. You gotta see what they look like. Do they look like they have a sudden decrease in level of consciousness? So you're gonna be doing your level of consciousness check. Does it look like they have um does it look like where when they're being irrigated, does it look extra bloody? They have extra discharge, more bloody than expected. Maybe they're bleeding more than they should be. But that level of consciousness is going to be an important thing. So obviously, you always want to establish a baseline so you know what the patient looked like when they came in, and so you can actually catch these acute changes um, in condition. And when someone does have these changes in condition, that's for you to pay attention to it because it can spiral down and lead to other worse things happening. Yeah, like a blood pressure. How often do we assess? Is it every 15 minutes? Um,
It's specified
Yeah.
on here, typically after
yeah, if it Probably, probably for the first hour or so, maybe like every 5 to 15 minutes is not bad. Probably every 15 minutes after a procedure, I think is policy in some places. And then kind of lower it down as they keep getting back to normal.
They specify.
Yeah, they don't think they specify. Yeah, I don't think they specified for us in the PowerPoint or the lecture, but that's something that makes sense. To me is post procedure kind of assess. I would say Q15 for the first hour. Take a second to assess their vital signs, check the patient out, and then after that, you can lower it to, whatever whatever time for that. Yeah, whatever your policy is for that. But do what makes sense, do what feels right, in terms of that. Depends on the MD order. Sure. I mean, it's never wrong to come in and check on the patient. Doctor says assess them this often, and you're not really gonna do anything wrong assessing them more. Right? Just always use your best judgment. Remember, you are not, as a nurse, you are not the doctor's underling per se. You are your own, you have your own independent actions. So, you can always be independent on things that are within your scope. As a nose, that's good. That's great, especially because again, they're going to be on the CBI. So CBI, we can assess for kind of like how bloody it is and stuff. There's clotting and stuff going on. That's excessive bleeding. Yeah.
For continuous bladder.
Yeah. Yeah. So something to keep in mind is for your eyes and nose is that you have this whole system here. Maybe I'll make it a little bit big, a little bit more easy to see. So with the CBI, it's basically like a three-way catheter, Foley catheter, essentially. It's basically your standard Foley catheter, but it has an extra line. So that catheter is going to have your one catheter that goes inside the urethra and inside your bladder and then connects to the Foley bag. It's going to have that one port for you to inflate and deflate the balloon, and it's going to have an extra line that connects to this bag that has fluid for irrigation. So the thing to keep in mind with your I's and O's is that everything that gets irrigated, so all this fluid here in this bag is going to go inside the bladder, and then that's also going to be coming out back into this drainage bag. So you're going to need to keep in mind to not count the irrigation for your I's and O's, or you can kind of think of it like going in and then going out, because it's essentially going to go in and then go out. Yes. So remember to keep in mind irrigation. Which example of that? If 2 liters of irrigation goes in and 3L out, you have a total output 1L. Does that make sense for everyone? So even though you had 3 liters come out, it's not exactly 3 liters actually for their output because that was some of the stuff you're irrigating in. So I think it's you don't count it for your input, you don't count it for your output either.
I think it just depends on how you do it. That way where you're just not looking at that at all, or you're like, oh, I put 3 liters in and like 2 liters came out. But
yeah, so if you guys can't hear Kaylin too well, basically what she was saying was that you could do it like how I just mentioned it, as kind of just ignoring it, or you could even kind of write it down, taking both into account. So you take both the irrigation going in and document it as 2 liters irrigation went in. Really? Huh?
Because you're trying to document your true INO.
Oh yeah, but you could in theory be like irrigation this, true INO is this kind of thing. Yeah, you could do it either way. Whatever makes, as long as you just kind of understand that your true output is only going to be the 1 liter. because you don't want to count the irrigation. Okay. Let me see what else there is to keep in mind. Yeah, just make sure to assess for clots and stuff. That's something that can happen with the CBI. Remember, you just had a surgery there, so the chances of there being clots from the fact that there was a surgery placed on it is something that can happen. So you can have those clots get stuck into the tubing. So you might have to what's the appropriate terminology for going like
Are you referring to milk?
not milking it, like pinching it down, not pinching it, not like not stripping it, but like you mean there's a thing going like this.
They're just referring, I don't know a term for that. You're just referring to like breaking the clock.
Yeah,
But that would be in the bag already.
it depends. Something gets stuck in the tube.
Well, yeah, no, it gets stuck in the tube and the tube, it's literally just like.
Hmm.
Trying to do it like that won't really work. I work for the
Talk about the clots.
to do, tell them like if they. I'm asking if you have talked about certain things, cause
Oh.
I was a little.
Oh yeah. Well, right now
distracted.
we talked about bladder irrigation and the eyes and nose, and that's as far as we thought about them.
Okay, so you haven't talked about bladder spasms yet?
No.
Okay, cool beans. So yeah, you could have bladder spasms after, somebody commented, when can we increase or decrease irrigation? Oh, that's a good idea, because I don't think that they really told you guys. I think, at the beginning it's gonna be pretty high. Usually comes out, you'll see like a progression. So it's first, it's gonna be pretty sanguineous, it's gonna be pretty dark, then it gets serosanguineous, and then eventually it'll turn to yellow. It's usually DC'd after 24 hours, but if there's some kind of complications, if there's blockage, if there's so many clots still and we're not irrigating it out properly, they might be longer. But they'll just kind of be based off of patient assessment and condition. But yeah, so like he was going over, you could have clots in the irrigation system. What is a physical sign symptom that the patient will complain of if they have clots in the catheter? What's something they might complain about? Wait. Pain, technically, yeah. Some kind of pelvic pain. Where are you at? You further down? Going over this. Pelvic pain, I like pelvic pain more. Distension could be possible, especially if they are retaining that. I would be concerned. What I was trying to go for is sometimes when you have clots within the system, they will complain of like bladder spasm. So it goes around with like pelvic pain or pain in that area in general, that they're having a little bit of spasming. So at that point, you might want to give the ditropan or check the system for the clots and possibly irrigate it like by hand to get them out. But the distension reminded me of something. I'm not sure. Did you go over? Did you? Where's
Mm-mm. I was
you
right.
didn't go over this yet?
No, I was
Okay.
here.
Oh, got you. You're drinking your smoothie. I've taken over the session. Okay. But the distension reminded me of something because sometimes with this system it can get accidentally absorbed. What is this condition called, or syndrome called, if it was to get absorbed? Absorb. Absorb is such a weird word to say. Right now I'm not saying it right anymore. Any random cracks at it? TERP syndrome. That was something I had a hard time understanding in 220 just because I felt like I didn't
get the way that it was described to me. But in basics, sometimes as you're irrigating it, it could get absorbed and you end up with overload, like fluid volume overload. So you're gonna see basically like your CHF patient because I believe it can cause hyponatremia, a dilutional, because we're absorbing fluids. Fluids. Haha. I like saying fluids like that. It could cause hyponatremia. It does have different electrolyte I remember from what you guys were given in your PowerPoint and in your lectures, it just says electrolyte disturbance. I would not be surprised if hyponatremia was there. That would probably be your main one affected by fluid volume shifts. But you would be mainly seeing your CHF exacerbation patients. So we're going to see shortness of breath. We're going to see dizziness, headache, crackles in the lungs, hypertension, altered level of consciousness, possibly. That's a fear. Oh my God. This doesn't really commonly happen, but if it does happen, it should be reported immediately because we need to figure out what's going on and possibly stop the CBI and treat their overload at that point. I realize I haven't been typing this chat. Can you type it? Can you type it?
Oh.
I realize I didn't type anything.
Oh, well,
I'm so
I don't
sorry.
even know. So,
I just basically went on all the points that you probably would have gone on.
let's see. How do I even write? Okay, here we go.
You give the link to my TED Talk.
So it's like about TERP syndrome. Which is essentially the irrigation fluid absorbs and causes overload. So you want to think about your CHF people. Headache, crackles in the lungs, hypertension. At the level of conscious, electrolyte and man. Cardia. And it sounds bad, and it is bad, so report it.
Fair.
That's something to keep in mind. So don't be surprised if maybe there would be a question where you have this and you're trying to figure out what's going on, and yeah, yeah, something like that. You'll have to like tell which one it is and stuff. With your CBI, you can expect pink fluids that eventually return to normal yellow, the normal yellow color. Jennifer says CBI would be DC normally within 24 hours if there's no clots. Yes. So you should expect a DC after 24 hours, assuming no complications.
About to type assuming no complications in the,
Oh,
in the
really?
chat, like word for word.
Yeah. So yeah, that's something to do. And within those 24 hours, you're obviously going to be checking that your your output is going kind of from a sanguinous to serosanguinous to yellow, essentially. And I don't know why I didn't do double. And then thankfully we have technology, so I can fix my correct spelling. Guess that's how you're supposed to do this. Okay. And then lastly, we also mentioned the bladder spasm. So they're assessed for the bladder spasm. When you have bladder spasms, it can be related to clots and stuff. So that's something that they can patient can complain about. Patient. Tubing, and you might have to manually irrigate it as well. And you can also give antispasmodics. So that's your oxybutylene, aka didropan. Okay. So let's see. Miss Kaylin did a great job
Yes, girl.
taking over. Miss Girl did a great job taking over while I had my smoothie.
I did not. I failed to type everything. I didn't think about it.
It's okay. So some complications that we'll just go over because I want to make sure we have enough time for everything. Blockage. So you want to assess the patency and make sure there's actually constant output going on. Assess patency, attempt to flush, manually flush out. And there's perforation that can happen. So if we got a bunch of fluid going on, we have this vessel's just like a specific size. Over time, you keep putting too much fluid going on, too much pressure. Pressure makes things pop. Pop makes things go rock.
Off goes the weasel.
Yeah, so just that in mind for that.
Preparation.
All right. Any questions on anything prostate related? 'Cause otherwise, we're gonna move on to kidneys so we can have time to get everything.
Kidneys. I like the kidneys.
Kidneys.
I like butts.
Let me just kind of take a look at what we got planned for kidneys. Should be okay on time, actually. We did good. I think we made good time, good progress. No questions? Okay. So the way I split it up is I kind of wanted to focus mostly on nephritic versus nephrotic. And then I have nephrolithiasis, the kidney stones, more towards the bottom, pyelonephritis. Just kind of talk about it on some part. Talk about this later. Testicular cancer, I put on the back burner, but I kind of gave you guys all the information there. And if we have time, I'll just read through it. Okay, so nephritic syndrome, also known as glomerulonephritis. So itis meaning inflammation of glomerulo, meaning like the glomerulus, which is your little loops that do the filtering in the kidneys, and nephron meaning kidneys. So inflammation of your little kidney tubules and kidneys, which is actually exactly what it says here in the definition. Okay. Inflammation of the glomerulus, which causes some ischemic damage. So kind of how like your heart when it's not getting enough perfusion or enough oxygenation in general, it gets damaged. Think about like your MIs. Same thing when your organ doesn't get enough oxygenation, it starts to necrose, starts to die. So in this case, though, you can have issues with you're gonna have issues with your kidney, so it's gonna affect things you would expect to be managed by your kidneys, which includes your urine output, um, your electrolyte balancing, so your potassium and stuff, your acid base. But the main defining trait of nephritic syndrome is that you're gonna have uh blood seeping through. So that ischemic damage leads to uh pores becoming more permeable, so like allowing things to go through that they shouldn't be going through.
Like
And yeah, and so it allows blood and proteins to filter through and make its way into the urine. Okay, so that's like the big defining difference is that blood going in. Some of the causes that can cause it, causes it. I kind of split this into acute versus chronic, but for your acute causes, I wrote down the group A streptococcal infection. So you'll see group A streptococcus for a lot of stuff as like it likes to get around and do mischievous things. A lot. It's can be the cause, the starter for a lot of different things. Let me just rearrange my setup. And the condition that they specify is like impetigo, which honestly I don't even remember what that is. So let's the condition that children get. So I think this is more common in children. Yeah, it's the school source. So Nephritic syndrome is something that I think is more common in children than anything, but it can develop over uh or yeah. Generally caused by some other infection that eventually causes kidney infection. So skin, it's mentioned here. That's what impetigo is. So this is your sores. Okay. So here's kind of where you guys can chime in, and that's your manifestations and management. So what do you guys got for manifestation of nephritic syndrome? So we do have proteinuria. Would you say it's a lot, or how would you classify that amount of proteinuria? It's a small, yeah, it's a small amount, especially when you compare it to its its cousin nephrotic syndrome. So we did mention that what's your most defining trait? I did mention it, but I want to reemphasize. I want it to come from your guys' mouths or keyboards, whatever. The very key defining trait. Yeah, exactly. So that's the hematuria. And very specifically, I see um I tend to see that they like to refer specifically a lot of questions I see like to call it a cola colored urine. I see that a lot.
Coca-Cola.
So because of that cola thing, that's why this picture I like because it has like the Burger King guy. Act- he has a Coca-Cola colored urine. Although the reason he's here is for something extra that we don't really need to know. It's called Burger's disease, but it doesn't really matter. I just like him having the Coca-Cola because that reminds me of that phrasing. Because I don't want you guys to see cola colored urine and not understand what it's referring to. So we're having issues with the kidney, and it's coming from a previous infection, and it's kind of causing inflammation. So what are some labs that deal with inflammation and kidney issues? So we have Caleb mentioning the decreased GFR. So let's kind of kidney labs. What are some other kidney labs you might expect? Increased BUN and creatinine. Hmm. Okay. What else might you see with an inflammation based condition that kind of comes from a streptococcal infection that eventually affects the kidneys? CRP can be one. I don't think they specified that for that one, but I wouldn't be too surprised if it shows up. What about something that you might see in your CBC? What kind of put Yeah, so remember that your white blood cell count is not just infection. This comes from can be caused from an infection, like that leads to kidney damage, but it's not directly an infection. But your white blood cell counts are not just telling you there's an infection, they can also tell you that there is just inflammation in general. So I think with this one, a CRP wouldn't be surprised if that's elevated, but I think they don't specify it as some of the things. I don't think it's specified in here. Maybe it is. Let me double check. But if it's not, it's probably because some of the signs for it are specific enough that there's no need to do something extra. Because having the urinalysis and just looking at the bloody urine and having the kidney labs affected, and then looking up at their history that they had a streptococcal infection a certain amount of time ago. it's enough for them to probably be able to diagnose it to the point where they wouldn't bother with the CRP and stuff like that. But yeah, it's an acute because there's a rapid onset, so keep that in mind. It's gonna have a rapid onset. It's acute, there's a rapid onset. What else you guys mentioned here? RBC, yeah, that could definitely see that happening for sure. With your CBC, you'll probably see decreased HNH because it's meaning RBC. Yeah, there's some mild edema as well. So you do have some sort of kind of mild fluid overload as opposed to the other one where it's a bit more pronounced. You'll have like mild edema, and it seems to be a bit more focused in like the face, eyes. You could have hypertension going on with that. You could have shortness of breath and crackle stuff. So kind of going along with your kidney labs, um, when your kidneys are not working too well, what is something you'll see decrease as well? It's not a kidney lab, but something else that you'll see decrease directly involved with your kidneys.
Is it your albumin?
Your what?
The albumin?
I think for this one, there is some albumin leakage, so that's a lot of your protein. But I think compared to the other one, it's not as bad.
Oh, okay.
But yeah, that's definitely something. So that's this proteinuria here is probably albumin and some other proteins. So you can see some of that. That's kind of what's causing some of the mild fluid overload happening. But remember that it's a small amount, so it's not as bad. But yeah, that is for sure one. I was looking for oliguria, so decreased urine output. So when your kidneys are really bad or not working too well, you'll have less urine. You'll have decreased filtration, you'll have decreased urine output. So the definition here that they went with the book is less than 300 ml in a day. Although you'll see different numbers in other lectures, but for this one they went with less than 300 ml in a day. But yeah, everything mentioned here is good here. Is hyponatremia associated? When you have kidney problems, hyponatremia is something that can happen due to hypertension, but they don't seem to emphasize it too hard on here. Acidemia, yeah, that's like a buildup of waste. So um yeah, it kind of goes along with your lack of kidney. So I can write that. Just remember, what is acidemia? Or what's the definition of acidemia? It's a buildup of something in urine, nitrogen. Oh, in blood. Oh, aciduria would be. So emia would be in your blood. Yeah. So where is that nitrogen? Where is the nitrogen? Comes from the. So that's what the BUN is. If you remember what BUN stands for, is what does the B stand for? Uric nitrogen, blood urine nitrogen, urea nitrogen. Yeah. So that's where that nitrogen buildup is. So that acidemia buildup of waste in general, but specifically nitrogen, that kind of goes along with your BUN. Because remember, your BUN is something measurable that your body will get rid of through the urine. So if you're not able to urinate, it kind of stays around in your blood. So that's the nitrogen specifically being referred to is the BUN in your blood. And also it will be in your urine, more concentrated in the urine because there's not uh, having retention and high concentration of urine and stuff. Something else is uremia, so that's buildup of uric acid in the blood. Kind of goes with that. Buildup of okay. Any confusion on anything here? This is like a very big key defining fact. Um, Good thing to keep in mind is that it's a mild fluid overload. And some electrolyte imbalance, you can imagine. Probably like a hyperkalemia, and I wouldn't be surprised if you have a hyponatremia going on. That's typically what happens when you have kidney problems. You have fluid retention, inability to pee, so it all builds up. That would be like dilutional hyponatremia because everything is starting to accumulate and not get treated out. That makes sense. Okay, so what about your management for that? Fluid restriction. I think they specifically kind of talk about treating the strep, so treat strep. So that'd be with some antibiotics and stuff. There is something to you do want to manage fluid volume overload. Want to be careful with the fluids that's already going. You already have a mild fluid overload. You don't want to make it worse. Um, some of the things you can do is yeah, you can do diuretics. You want to assess the lungs because the worst possible thing that could happen is having pulmonary edema and stuff, um, things like that. Yeah, you want to also manage the electrolyte imbalances. So you want to keep potassium in bay or like manage potassium in particular because your potassium will be high. Like that. I noticed in your guys' notes you have like a low sodium diet. That's more for um preventing more retention. But in terms of themselves, their sodium would probably be a little bit on the lower side. I'll double check though, but that's typically what goes on with the kidney patients. That's why kidney diets are so hard, is because they'll have these electrolyte imbalances, but they're also having issues with overload. So it's kind of having some contradictory treatment because you have to treat one over the other. At some point, the hyponatremia is to a point where they have to provide more sodium or it causes seizures and stuff. So that's why kidney diets are really difficult and so restrictive. So let me double check up on that. Limit protein, they say. Kind of like when your kidneys are, even though you are losing some protein as well, your kidneys are at a point where they are allowing protein to leak through, and all that protein can be damaging to the kidneys. They're trying to filter the proteins and it's causing damage. So another part of your renal diet involves lower protein. So limit protein use damage to kidneys. Proteins are big molecules, so they can damage the tubules when there's stuff going on like that. Um, let me see. Like antihypertensives. So let me double check up on that. One more thing, if it's inflammatory, then we can also manage with corticosteroids. Okay. Let me know if you have any other questions on this. Right now, I'm gonna look up the sodium thing just to double check up on that. What's Sebastian? Oh, what's this one, Sebastian? Yeah, from what I'm looking up, it's kind of coincides with what I mentioned about the hyponatremia. Maybe not so much, probably more so over a longer period of time. This is a really good one. Um, yeah, this is pretty good. I will. That was from Simple Nursing. Okay. Yeah, this is a really good one. Yeah, go ahead and download that. That seems like it's a good resource. But yeah, I think the thing about it is that you don't want to intake. They want you to do like a lower, like a sodium restriction rather than like a sodium, like no sodium at all, because the sodium will cause more fluid retention, but at the same time, hypokalemia is something that will happen over time. So just kind of keep that in mind, the protein. So you also want to limit fluid restriction. We already mentioned that or not. I guess here we can do here fluid restriction, um, sodium restriction. But keep in mind of dilution will happen. So over time, we are worried about the sodium getting too low. So manage potassium, assess for hyperkalemia and hypokalemia when if having high diuretic usage, because remember a lot of the diuretics are going to be potassium wasting, so you can go the other way. But I can imagine that initially you will have your, if you guys remember your RAS system, that retention that's going on is because your RAS is causing retention of sodium in water. So they want you to kind of restrict it so that you're not retaining as much, but want to keep in mind that over time your blood will become more diluted and your sodium will become diluted because of all the other stuff that's in there. Your potassium is starting to take up more space, your fluid is starting to take up more space, and the sodium levels are overall going to be lower. So you'll need to, yeah, so seizure precautions are good for possible hyper. It can lead to seizures if and neurological deficit if less than 1.85, I think it is. So once you hit that level either between 120 or 125. Less than that, that's when the patient will have kind of like this look as if they were neurologically declined, risk of seizures increased and whatnot. Okay. Anything else on nephritic you guys wanted to, or you had any questions on? This was just acute, so we'll go over chronic next. And then for the sake of time, I kind of just wrote down the causes. So for chronic, the things you're looking at is things that might cause kidney issues. So like a kidney infection, inflammation, hypertension, lack of good perfusion, because remember your kidneys need good perfusion, or they complain. Lupus, which is there's a lot of different types of lupus, but lupus can be like a systemic inflammatory autoimmune condition. So that can cause issues with the kidneys as well. It develops over years and will always lead to a end-stage renal disease. So a chronic nephritic will always lead to ESRD, which probably means patient is gonna have very low urine output, maybe even and issues with electrolytes. They might not even make urine anymore. They might need to be on dialysis. Uh, but it does end up having a lot of the same symptoms. So you'll still have that hematuria. You'll still have the mild proteinuria. You'll have some fatigue that goes along with it. You'll have fluid overload. And I think with your chronic, the fluid overload becomes a bit worse, is a little bit less mild. So probably a little bit more attention on the fluid overload aspect. So you'll have edema. You'll need to assess lungs and stuff. Worry about their weight. Do like daily weights to see if they're retaining fluid and stuff. JBD, if you guys remember that for your when someone's in overload, they can have that engorged jugular. You're gonna want to do like your eyes and nose and stuff. Some other manifestations, they'll still have the acidemia. The same labs will pretty much be affected. They can have some neurological changes. And I can imagine a lot of this comes from, like I mentioned, when you let over time the acute, when you have these kidney problems, will eventually end up with dilutional hyponatremia. These people that are chronic are probably going to have more issues with the hyponatremia over time. So you'll see probably more neurological changes due to the low sodium. So kind of like the ataxia, which is ataxia slash like a lack of balance. I don't know what that means. Slurred speech. So someone with really low sodium, like less than 125, maybe like less than 125, less than 120, like around that area will kind of almost look like they had a stroke almost. How they will like kind of look. Some labs, let's see, they'll have more significant renal failure, might need dialysis, like we talked about. If they're going ESRD, then that's what that's gonna kind of come with. Some labs similar to the other ones, so your kidney labs are still going to be decreased GFR. You'll see increased UN and creatinine. You'll see elevated white blood cell count because of inflammation. Um, and then there's like something interesting is that you'll have like a specific gravity, very specifically at 1.0110. And trying to remember the rationale, but there's when your kidneys are damaged to a certain point, your specific gravity ends up just being at this rate. I can't remember the exact mechanism, but I just know that that's something that happens. So I can look it up, but it's trying to get through this within the time. So we have until 3. So I'll look it up probably later, just to save time. And remember, these people are gonna have hyperkalemia, hyperphosphatemia, so phosphate. So when someone has high magnesium, high phosphate, that's increased risk of cardiac dysrhythmias. Maybe some dilutional hyponatremia. Because remember, your kidneys are gonna get rid of potassium, get rid of phosphate, and then not that one. And you'll see your kidneys are also kind of in charge of your acidosis, maintaining, keeping you from being metabolic acidotic. So you might see some metabolic acidosis happening as well. And then for the management, I think it's kind of the same as, I don't think they actually go into high emphasis on that. They actually don't even have anything on the management, but it'll probably be on a lot of the same stuff. Can't just remove it. Focus is probably a bit more on the acute, but just kind of understand that it's a lot of the similar stuff. Um, yeah, any questions on anything? Anything that you guys want me to explain? Some of this is pretty much like the same stuff, just a bit um, more bad, I guess, or because it's chronic, it's happening over longer periods of time. Um, Let me know if there's anything you guys are confused on. Oh, okay, so that's the reason for this. If you were wondering why this is specifically at 1.01, this is the it's the specific, it's the concentration of plasma. Essentially, um the kidneys are losing the ability to concentrate the urine. So if this is just gonna have the same concentration as your blood, or a very similar concentration as your blood. So it's gonna stay close to the concentration of plasma. Just extra information if you're wondering. So it can the ability to concentrate and lose urine. Okay. Now we can talk about nephrotic syndrome. So I wrote down for you guys just the causes. So typically caused by autoimmune inflammation, genetic defects. This one also has an increased permeability of the glomerulus, but this is going to lead to more extreme leakage, and it's going to lead to very much a large leakage of protein. So the way I like it here is how they emphasize the O for protein. So nephrotic with the O, protein. So that's how I can remember it easily. And then in the picture here, I like that it has a little dog and he's like, I'm gonna get buff because there's so much protein. Yeah, it's mostly albumin, but yeah, so kind of like in the other one, a lot of that protein that is lost is albumin, just like in nephrotic, but it's to a much higher amount, so it leads to more third spacing and stuff. So we already kind of talked about that. So large um proteinuria. And this includes albumin. It includes one more, not just albumin, but there's another thing that you're also kind of, a few other things that you're losing out on as well. That might be interesting to keep in mind. I don't even know if you guys actually go over this or if this was me being extra. I think one of these you guys should know, actually. Other types of proteins that that you lose in your urine. And then maybe when we get to management, you'll see the connection. So it's another group of proteins that your liver makes. And I'll give you a little bit to think. Otherwise, we'll move on just for the sake of time. Your liver makes albumin. It's also making a different type of protein. Um, so bilirubin I don't think bilirubin technically is a protein. No, so bilirubin, the kidney doesn't actually make bilirubin. The kidneys process bilirubin into bile. Bilirubin is from the breakdown of red blood cells by your spleen, typically. Your spleen will destroy used up, dead, abnormal red blood cells, and then your liver will convert the bilirubin into bile, stored in the gallbladder. Globulins, so that's another one. That's good. So that's immunoglobulins. So you can have increased immunity as well from the leakage. And there's one more. I guess at this point, I'll just mention it. It's actually going to be your clotting factors, your liver. Some of the your clotting factors are actually proteins that your liver makes. So that's going to be affecting your PT and INR, your APTT and stuff. But yeah, the main one being lost is your albumin, though. So it is mostly albumin, like Kayla mentioned. But these are some other things that you'll see. So there can be a decrease in immunity because you're getting rid of your immunoglobulins. Oops. And then clotting factors show increased risk. So so that's how that kind of relates. Um, not directly related, I guess, but if you think back at your shock, one of your late stage signs for shock is actually like in your third stage, you'll have third spacing. That's because of your liver impairment. Your liver makes your albumin. So if you have liver impairment, you're gonna have third spacing. There's gonna be capillary leakage, but there's also going to be an increased risk of bleeding because your liver makes clotting factors. And that's another reason why DIC can come from shock. Remember, DIC can be the use it's when you use up all your clotting factors and stuff. Whether the clotting factors are being used up because of your body overreacting and making a bunch of microclots, or just like a severe loss of clotting factors. That's kind of like a connection alongside the shock also causing your body to freak out. But it's kind of like a combination of all the stuff there that kind of lead to that. And so when you do have proteinuria, what does the urine look like? Yeah, exactly. It's going to be a foamy, frothy urine that's showing that there is protein in the urine. So that's good. Yeah, it can be dark yellow as well. Dark, kind of weird dark yellow color, but frothy is kind of like a big sign of the protein in the urine is going to be your frothiness. I have manifestations. So now, what are some of your things you can do to help with this? Actually, I think I, for some reason, decided not to include some of the other ones. I think that's just like the main thing here. Um, I guess that's like the main thing, other than like edema and stuff, because obviously you're gonna have edema due to all that other stuff. Hyperlipidemia. That one might seem a little random, the hyperlipidemia. The rationale behind the hyperlipidemia is that the way your body works, it's fats in the urine, no, but fats, well, I guess you have some fats in there as well. So some of the other stuff here is like your lipoproteins, and lipo meaning fat. Yeah, exactly. So your body, your liver essentially is gonna make more albumin to compensate, but your liver also makes cholesterol and triglycerides. So your body is kind of overcompensating, liver overcompensating in attempt over albumin, and also makes too much cholesterol and triglycerides. So you'll have a buildup of fat as well because of that. Glyceride. Cool. And then for edema, I'll specify that it starts in the face, around the eyes, then moves on to extremities and abdomen, and it's more severe than in nephritic. And now we can move on to the management. So we said, I think Caleb said albumin, pretty much just increase your protein intake. So even though with a normal kidney diet we want to decrease, the amount of protein loss is so much that we have to recover it. So we're going to increase the protein intake, and yeah, you can give for sure some albumin as well to help with that. Remember that the some of the etiology is um increased permeability usually that's from inflammation and stuff. A lot of these autoimmunes cause inflammation. That's like a general thing to keep in mind. So if we are going to be having an inflammatory condition, what's like a medication you guys can think about that decreases inflammation? Yeah, you can do steroids, decrease the inflammation and the amount of protein loss, because if you have less inflammation, you're going to then have less capillary leakage, which means less permeability, which means less protein being lost, being escaping. They shouldn't be. Um, Plus, Kayla says no anticoagulant. I can imagine that just because one of your interventions here was just like to assess your APTT and INR, PT, INR, because you are losing some of the protein losses, clotting factor. Even I don't think it's directly stated, but it kind of makes sense that you want to be really careful for bleeding. Jennifer says if we have decreased GFR, we decrease protein intake. We have clarify a bit. Because actually this will have I guess they don't specify in your notes, but this person I think will also have increased BUN, granin, and a decreased GFR. The purpose of the main thing with this one is that you need to increase the protein. I think it's not mentioned anywhere, so I will look it up to double check, but you'll probably still have any labs will still be kind of messed up. Where I get this. This what exactly will help with the loss of protein? Kind of like I mentioned here, the loss of protein is being caused by the increased permeability. I guess I'll put due to inflammation. So if you decrease the inflammation, that's gonna help with the with that. So you can see this one here, right? Steroids are gonna be good for inflammation, and so if you are gonna be decreasing the inflammation, you'll have less leakage, and then you'll have less protein loss. Does that make sense? Yeah. So something they also mentioned here is to administer ACE inhibitors. So the ACE inhibitors will do a few things, but remember if you're having all this retention and stuff, I guess I don't really know why they don't go into full detail in your guys' PowerPoint on some of the labs, but it is pretty similar to the other one where you'll have your kidneys are um gonna do their thing and whatnot. But so you'll have similar lab stuff, but you'll still have like the edema, the retention, so you'll still have some issues with your like hypertension and stuff. So it helps with hypertension, but it also can helps to decrease the protein loss. You actually don't want to preserve. Okay, so you do want to be careful with your hyperkalemia with that because the main reason for this in this scenario in this context is because it helps to decrease protein loss. So even though people with kidney problems have problems with potassium because their bodies aren't getting rid of potassium, ACE inhibitors might still be given for blood pressure as well as for protein loss. So you'll see that for ACE inhibitors, and even though it's not in your guys' notes, they can also give calcium channel blockers. Can also be given for this purpose, specifically this purpose here. In this context, it does that. So even though people with renal stuff will have issues with potassium, they do that for this specific thing. So then if being that is good that you notice that you should look at your potassium with that. Like the renal patients will have issues. Paper. Okay. Remember your ACE inhibitors will increase your potassium. Inhibitors. And you guys remember the rationale is that it inhibits your RAS, and if your RAS, your aldosterone is gonna be retaining sodium and water. Another thing it does is it actually gets rid of potassium. So if you have less of that hormone that your body uses to get rid of potassium, then it's also gonna lead to an increase in potassium. And says if a patient has a low GFR, their protein will be low. Not necessarily. Low GFR is okay. So to be to give you a very quick like explanation on like kidney stuff, your GFR is your filtration rate, which is kind of based on the amount of creatinine that your body gets rid of. So the reason we measure creatinine in your blood is because the body has zero use for creatinine. So it is going to be your primary thing that one of your primary things that your body gets rid of in the urine. So if your kidneys are having issues, they will not be able to filter out creatinine effectively. But because it's so important to get rid of, your kidneys will fight until the bitter end, get rid of creatinine. So with your people with high amount of kidney damage, that's when you'll see the creatinine increase. So you'll see creatinine increase once the kidneys are already like very heavily, like already having some issues because your kidneys are trying their best to get rid of creatinine. So by the time that it gets to a level where the creatinine, they're not able to manage it, it's kind of when they've already done their best and they're kind of failing at doing so. If that makes sense. So your body does its best to your kidneys do their best to get rid of creatinine. And your body's so like persistent with getting rid of creatinine. And that's why we use it as a measurement of kidney function because that's the thing your kidneys are always trying to get rid of. That's why we measure creatinine. So by the time that it's starting to increase in your blood, it's kind of showing you that the kidneys are already suffering some sort of impairment or damage. And your GFR is based on your clearance of creatinine. So if you have a kidney patient, you might see that they might have done a creatinine clearance lab, which is more accurate than your GFR. Your GFR, you usually see it as an eGFR. The E is for estimated, so it's an estimate. It's not exactly accurate. So if there's a kidney patient that needs to be assessed for their dosage on their medications, because remember your kidneys are also going to be clearing out meds. So a patient with kidney problems can have their can get like toxicity more easily if their kidneys are failing. So they do renal dosing. The renal dosing is based on their creatinine clearance. I know that's a lot of information, and a lot of this stuff you won't learn until third semester, but maybe it clears a little bit of confusion. But to be specific, it doesn't have I don't believe it has a direct correlation um, with what you were asking, Anne. It's just that in this instance, we are losing a lot of protein, so we need to get more of it. And in this case, the protein is leaking, not because of our filtration rate, but more about our inflammation leading to the permeability of the glomerulus being less. So kind of remember that that experiment in like high school where they put like sugar in a little bag. I think it's like sugar water in a bag, or was it? I think was it sugar water in a bag, or was it? I think it was like sugar water in a bag, and they put the bag into like a bowl of water, and then the water goes through the bag and um into your other smaller baggie and kind of pumps it up. That's essentially what's happening. That's essentially what happens when your vessels are permeable. Things will go through, but there are how do you say your body has ways to change that permeability and kind of prevent that from happening. I'm not sure if I explained it well, but I'm just trying to relate it in a way that might make sense. It's just your kidney tubules allow certain things to go through. When there's inflammation, they allow things they shouldn't allow to go through. maybe think of it like your tubules are like a bouncer at a club. Their job is to block the protein from leaking, let's say. But now they have an extra problem to deal with. They have inflammation that's kind of distracting them, and they allow things that they shouldn't be allowing to go through into the club. Does that make sense? That's the rationale behind the permeability. Let's see what else we have here. That's, I think, what we have here. ACE inhibitors. I think diuretics, we can decrease the fluid volume overload. Administer diuretics. You decrease edema, and again, you're monitoring for your electrolytes because diuretics are affecting your electrolytes. Let me see if there's anything here that you might want to do. I guess you can do, again, fluid restrictions and sodium restriction. Just manage your fluid volume overload. So sodium restriction, but also monitor your salt because you can have low salt too. So just be careful on that. Kidney patients are complicated. Your kidneys does so much, and when they're impaired, it causes so many things wrong. Causes electrolyte imbalances, fluid imbalances, causes acid-base imbalances. So yeah, it's a really important organ. So yeah, it's so important that fun fact, your more blood goes to your kidneys than your brain. That's kind of an interesting fact. Let's see, give we already mentioned diuretics. Measuring, give diuretic, probably like fluid restriction would be good. And obviously you want to monitor your urine output and your I's and O's. You don't want the patient to have an acute kidney injury, which you'll learn more about third, but you always want to think about this kind of stuff. You want to make sure the patient has good urine output. So like something I tell people a lot is that it's not it's easy to kind of just focus in on the heart and the lungs and neurological, but you also got to think about if they peed throughout the day, if they pooped throughout the day. So things to keep in mind. If they're not peeing, you got to find out why. Are they dehydrated and then we mess up their kidneys for them, or are they so constipated they have an obstruction and then perforation? And remember what happens with your perforation. You have shock, peritonitis, hemorrhaging. So things to keep in mind. All right, I think that's everything for that part. So here I have this image, and I went through it again. The cola colored urine is what you might see in questions described, used to describe the bloody urine. There's some extra information here. I just like it for the Burger King, the cola colored urine. I like how it shows that the little kidney tubules, the glomeruli, are being kind of constricted. You see the hypertension, you see the oliguria, you see why. It kind of gives you like a little picture that kind of makes it make sense on why it's happening. It's being stretched, it's being constricted too much, so it's not able to pee out as well. And then on the nephrotic syndrome, it has like an emphasis on the O for the protein. It has the dude looking at his edema. It has a picture showing that there's hyperlipidemia. There's less albumin because you're peeing it out. And there's so much protein loss that this dog is like thinking about getting buff because he's drinking the protein pee. Um, yeah, just let's see what else is in. Kidneys are a complicated organ, but hopefully I highlighted a lot of the importance. maybe clarified some burning questions on kidney stuff because again, you guys don't actually go into a formal kidney lecture until third semester, which is interesting because they made you do this kidney stuff here. But that should be everything for that. Here is a slide from your PowerPoint that I think is really important, just kind of directly showing you the differences. So small amount of proteinuria versus big amount of proteinuria. Red blood cell, like the hematuria on the Friedrich versus no blood loss. Have edema in both, but edema is more pronounced in your nephrotic, like we mentioned. And it's more pronounced that you have that hypoalbuminemia, so the loss of albumin in your blood because you're peeing it out. So you will have hypoalbuminemia, but you'll have hyperalbuminuria because urea is urine and emia is blood. Red cell cast is hematuria. Yeah, it's referring to the hematuria in that case. Okay, so now we have about 15 minutes to talk about kidney stone and pyelonephritis. I recall kidney stones being less emphasized, so I think just for the sake of time, I will just talk through it. And also, I'm sure you guys are getting tired. So kidney stones more common in men. This is their government name, nephrolithiasis. Some of the causes and the risk involve family history, insufficient hydration. So you can see it more commonly in older folks because as we get older, reflex to drink water is less. My dad has straight up said he doesn't like drinking water. Um, so that's stuff to keep in mind. Being overly diuresed can also cause kidney stones. So to prevent it, your key thing is going to be to increase your fluid intake. Going to be your key thing there. You're going to be careful with. I think a lot of the education on here is going to be on diet because your kidney stones are caused by like oxalate, I think it's so some of the foods that might be wanting to be avoided. So most of your kidney stones are like oxalate or calcium, I think. But I don't think you need to know that much in detail. Just kind of understand your fluid. You need to drink more fluids. Caution with calcium supplements as they so kidney stones can be made of calcium. One of fewer oxalate rich foods. So I have like a picture, and I don't think you need to memorize this stuff. A lot of it maybe you can kind of cluster on into get the general idea. But I have it just because I do, I guess. Something else you will see. So signs and symptoms now. See, Kellen mentioned there's something genetic or due to infection. I think the urinary stasis one, is that what you're referring to? That's the HIV, people that take HIV meds might get it. But again, I don't think that's as much of a focus. We'll just kind of start talking about the signs and symptoms. Mainly you'll have flank pain. So whenever you're thinking of pain related to kidneys, that's the flank pain. Whenever you're thinking of issues with the kidneys, you might want to think about bladder distension because you're not peeing, so you're gonna have retention due to retention. We talked about all that. So you're gonna want to assess your urine output and stuff. Frequency of urination, dysuria. You might have some blood because of that. Anuria, meaning no like failure of kidneys to produce no urine. So you always want to think about your blood and eyes and nose and stuff. Yeah, the renal colic, that's kind of like the flank pain. So it's specifically like pain on the back in the lower ribs and hips. So for some diagnostics, urinalysis, we talked about you can have hematuria, so you can see some hematuria. I guess, yeah, from the urinary stasis. So there might be some bacteria from your KUB, so that's your um I guess the X-ray. I think I called it an ultrasound room. The X-ray of your stuff. And there's ultrasound. Yeah, yeah, pretty much stuff that you can imagine happening for that. Maybe your BUN and creatinine increase. Maybe there's higher uric acid. Maybe your electrolyte count, your calcium or phosphate, maybe is high. Your management for that is going to be treating the pain because it hurts. You encourage the fluids because that's the reason that you know, they have the kidney stone. So obviously you're doing your eyes and nose, daily weights. Prevention of infection. So we can have bleeding. We can have the stones can aggravate the urethra and cause open entry, portal of entry for infection. So prevention of infection with antibiotics. So treating the pain, the specific set and sets. Um, Calcium channel blockers can dilate the vessels and allow you to pass the stone. You said that there's a higher uric acid, so there's a medication called allopurinol, which was brought up during your oncology emergencies. So to treat high uric acid. I think last they talk about diuretics to help move stones along, and you want to assess potassium. They specify thiazide, so these are similar to loop diuretics. They don't affect the loop of Henle, but they affect a different part. But they are both going to cause hypokalemia. Hypokalemia. Okay. Something else they can do is like a lithotripsy, which is that they will just ultrasound shock, US shock waves, break down stones. So did I mention antibiotics? Yeah, in fact, antibiotics, yeah. So that's something to keep in mind because remember they're causing portal of entry. Okay, there's 6 minutes left. Pyelonephritis. The testicular cancer is just written down. Pyelonephritis is basically the infection. We talked about earlier that the UTI can go up to the kidneys. That's the hydronephrosis. You can see kind of here. You'll have the some of it can ascend up from the bladder to the kidneys, and even if there's no urine, the bacteria can still make it there. And so you see this yellow spot, that's like the pus that's building up, that's the infection. It can be as bad as leading to ESRD. And let me just fill it out. If we run out of time, I'll just post it in the pronto. But I'll try to get as much of this done. So pyelonephritis, again, the main things you'll think about is going to be your flank pain. That's kind of what you want to think about with this anything kidney related. It's an infection, so fever and chills you can expect. You can expect some fatigue, painful urination, and you might see hypertension because if your kidneys can manage a lot of your. I remember with your RAS system, it has a big effect on your can have a really big effect on your blood pressure. Some of the things that you'll see, like a urinalysis, stuff that makes sense for diagnosing. We've been seeing them so often here. Urinalysis, cultures, a KUB, CT scan, you'll see swollen kidneys and stuff. I kind of underlined the stuff that I felt was important. This right here, the costovertebral angle tenderness. I've seen these in questions, so I wrote it down. Because I think before, like I've never seen specific wording used before, but that's what that refers to. And in the management, you can imagine that you have an infection, you're going to treat it with antibiotics and stuff. Pain management, you're going to potentially have a nephrostomy tube, which is something that they'll use to allow your kidneys kind of to ureters and kidneys to rest by having a tube that directly drains the urine from the kidneys, and you're going to assess for clots there. Just that's something that can happen. And percutaneous nephrolithotomy, which is removal of stones through surgery. Okay, I know we went through this really fast, but I think I got through what I kind of wanted to focus most on, which was like prostate TERP and then nephritic versus nephrotic. And then at the very least, you guys have all the information in this PDF, even if maybe we didn't get to interact as much as I would like. And then testicular cancer is what it is here. It's all kind of on there. So you guys will have it all in one spot. I'm going to stop the recording.